Dr. Andrew Chang from Australia, and he has been a very great support for me in both APAO and APVRS. I think we all know him. He'll be speaking on my infusion cannula is not in the right position, subretinal or suprachoroidal displacement of the infusion cannula.
Yeah, thank you very much, Bhuvan. This session is nightmares, and sometimes you know you're going to get a nightmare and it doesn't happen, and other times it happens and it's pretty terrible. These are my disclosures. We have modern vitrectomy techniques which make surgery reproducible and efficient, but in some ways when things are really automated and quick, sometimes we end up in trouble quickly as well. I'm going to share with you some cases where we've had issues. So we put an infusion line in, and where do we put it in? Well, we have to be aware, obviously, of the surgical anatomy of the pars plana, but things can sometimes be tricky. Some patients will have an anteriorly inserted retina, and also where the oroserrata is varies from the nasal side to the temporal side. We generally would put a cannula in 4 millimeters from the limbus in a phakic eye and 3 to 3.5 in a pseudophakic eye. High-risk cases that we anticipate we're going to have a problem. Total retinal detachment with hypotony should really raise in your mind the very, very high risk of suprachoroidal or subretinal infusion. Trauma cases which potentially can scar the pars plana are another danger case. And when you are manipulating the eye to do surgery, that's also when things can go wrong. And there are patients where the eye's been rotated and the infusion can move. So a couple of tips. When this happens, I'm thinking in my mind, don't tunnel the incision with the trocar, go straight in, make sure that the infusion line is very, very carefully secured, and heavy liquid can help to stabilize the retina as well. So, confirming the tip of the cannula, it would seem pretty straightforward, right? So we will look from the side, we would use a forceps and push it in. That is, we directly visualize it. And it's happened to me, and I may well have happened to you, where it looks like we're in, but we aren't in, or we're just in. And as the eye rotates, the cannula can get out of position and be underneath the retinal or under the uveal layers. So this is a case that I did about 2 weeks ago, and I thought this was a really high-risk case. It was a case that was referred from the Pacific Islands. The vision had been very poor for some months, a chronic retinal detachment, large choroidals, pressures only 3, and I'm thinking to myself, we are going to have problems securing the infusion. So I walk into the operating room and say, I want a 6 millimeter infusion line, but I also want 6 millimeter cannulas on standby in case I need it for the instrumentation. So this is the surgery, and I'm not tunneling, I'm going straight in 6 millimeters, and I look from the side and I'm not in. So I move in, I put my trocar in, I try and put my light pipe in to see where I am, and it glows red because I'm actually in uvea, and I can get in. Then I think I can come in from the other side and try to clear it, but that's no good. And so what do? I just make the infusion line from the nasal side. For some reason, and I've seen this many, many times, the infranasal port is often an access which has less choroidals. Many of the times the choroidals are on the temporal side. This is a case that my fellow was doing, and it was to be removal of a dislocated lens, intraocular lens, and she was preparing to remove it and suture 4-point fixation with Gore-Tex. So she's setting it all up. It's all going really well. I'm assisting her. She's making the infusion here. It's 25 gauge, all pretty straightforward. She continues to do the case really well. She's putting the first port in, the second access through the pars plana, ready to remove the lens and to suture the 4-point fixation lens. So case is going well, and you'll see that the lens is hinging on one side. We're really concentrating on getting this lens out. It's not easy, things are moving around, and I'm still, she's concentrating on the wound, I'm concentrating on the wound. You can see here that the IOL is being brought up. She's asking me, how do we get this out? Do I put it into the anterior chamber first? She's doing really well. She opens up the wound a little bit more, and we're so focused on what we're doing that you might look at what the infusion is doing, right? Both of us have not noticed this. She goes on to suture the wound. I said, you've got to be very careful here. Still haven't noticed anything. I'm watching her suture. I'm telling her how to suture. She's completely focused on a different part of the eye. And then I say, oh, your infusion line's about to come out. It's moved. And so we try to reposition it. We do get it actually back in. And we notice the red reflex has gone off, and we have got a suprachoroidal infusion with big choroidals there. We managed to drain some of it out. But the teaching point here is when we are moving the eye around doing things, that is when the infusion can come out. And industry is working on this. There are newer ways, and you will hear about it probably over the next couple of months, where you can secure an infusion line better. Just be very careful. It might be also at the end of the surgery where you're sclerally depressing with a cryoprobe, and the eye, the fornix is a little bit tight. So here, what did we do? Well, we abandoned the surgery in terms of suturing the intraocular lens. We did drain the choroidals, and then we're out, and about 2 or 3 weeks later, and the choroidals went away by the next day, we brought it back into the theatre again. But I said that we had an observer from overseas, when did the infusion line move? And no one saw it. No one saw it all because we were all so fixed on getting the intraocular lens out. So we went back, and this was a video that we had fortunately recorded, and it was out for a very long time. Now, this is a case of mine. It was to be a routine retina detachment, a pseudo-fake, very straightforward, and 23 gauge, and I enter, and I check it, and it's going all right. So as I'm doing the vitrectomy, I start noticing that I've got fluid, and furthermore, I've got more fluid than I started out with. And it suddenly occurs to me, probably about a minute or two into the case, I must have an infusion line underneath the retina. And that's why I'm getting this expanding fluid. So initially I think, well, I could flatten this off a little bit. So I make a posterior retinotomy and I try to remove fluid. I then direct myself, because I can't actually flatten it off. I see that my infusion line has slipped. It has gone now under the retina itself. And it's a pseudophakic eye, so it's a little bit easier. I try to free it up. And then I make another mistake. I think to myself, well, I can put air in. If I put air in, that will flatten the break at the top, and then I can drain it. But if you see now, I've got retina right up against my intraocular lens. The air bubble has completely dissected the retina and pushed it flat against the lens. There's vessels just behind the intraocular lens. So I shift my infusion to a place that I know is safer. I infuse, and you see these are when it was non-valved. The air comes straight out again because it's all sitting up the front. And I clear the vitreous that's near where I accidentally infuse the retina. Here you may use heavy liquid as well to stabilize the retina. And it basically goes back. As soon as you get an infusion, you push it into the interior vitreous, it will fall back again. And here, heavy liquid is amazing. So we've stabilized the macula, we reposition and stabilize the peripheral retina, and then we can go on to do the case. And in this case, we went on to just use standard gas tamponade. So risks and intraoperative malposition. This is the other problem that you might have, and be very aware of this. When you are manipulating the eye, this is when the cannula can come out. We aim for long scleral tunnels because we want to reduce the risk of hypotony and wound leak, but we are losing length. So if you really think that the choroid is a bit thicker for whatever reason, enter straight in. And subretinal infusion fluid can cause iatrogenic breaks, tears or detachment like the one that has happened with me. Subretinal air is a real challenge, and I made a error in decision because I thought, well, I could just go to air, flatten that peripheral area off, and I'd be fine, and I could go posteriorly to my retinotomy, and that would be not an issue. But air finds its way under the retina pretty easily. So corrective steps, stop the infusion, reposition the line, and you saw how we did that in several cases. You can use an MVR blade to incise any tissue over the infusion line, but I will tell you that that often is not successful because it will move again. Use forceps to advance a retracted cannula until flush with the sclera. That was the case in which my fellow inadvertently did not realize that the cannula had shifted. I use 6mm infusion cannulas very often. If I suspect that there are any choroidals, even small choroidals, I will use that. And in these cases, don't tunnel the incision with the trocar. Thank you very much.
Thank you, Andrew. Wonderful presentation. I think he has just shown how a normal, routine, uncomplicated procedure can turn into a nightmare. So, and I think you've shown how to handle all the cases. If you could just highlight on what are the signs, once you have done all your homework, you have put the cannula straight, you have checked your infusion cannula, but what are the signs that you should be careful of that probably your cannula has gone into the suprachoroidal or the subretinal space? If you would highlight the points.
It depends on where it is anatomically. So if it's under the retina, that is, it's more superficial, it will be, the fluid is not going away. Like in my case, it took me a while to work it out. It was a bullous detachment to begin with, and often a bullous or subtotal detachment, the uvea will also be slightly detached. And I thought this is not flattening off. So sometimes with the bullous detachment, we can't see the break. So you start in the center, and as you move around, you know where the break is because the fluid starts to flatten. In this case, it did not flatten. And it took me a little while to work out that I was actually infusing into the subretinal space. The choroidal space is a little bit, I think you can sometimes get away with it. Because even though your infusion line may not be wholly into the vitreous space, vitreous cavity, it can still infuse a little bit. So with my fellow, it actually was not too hard. We repositioned it and we kept on going.
I think this is
The
advantage.
reflex,
Yeah,
that's the
advantage
other
of
thing
the,
you were going, I think
having
you were
3
hinting
cannulas.
at. Yeah.
Any questions from the audience?
Can I?
Can I?
Yes, please. So can I ask you one or two questions that, what is your impression when we used to do 20 gauge vitrectomy and used to suture the cannula, we had very limited displacements of the
Absolutely. Absolutely. And that's the teaching point. With technology now, things happen so quickly
cannula. Yeah.
because it's easy to do. You just enter and you just assume that that will be sufficient for the entire case. You're absolutely right. When we were doing 20 gauge, we were in with a large, with the blade. We would put it in, we would secure it with a suture and it did not move
Yeah.
during the case.
So,
So I think we are seeing more of it now.
So we just have
and
to be
so maybe in situations like you had your first case where you had choroidal detachment and such cases, would you like to have a sutured 6 millimeter cannula and do a hybrid vitrectomy?
Yes, you could do that, or you'll hear more about it because it's commercial in confidence. There will be some infusion lines that and cannulas that are shaped slightly differently, so they don't slide out so easily. So that is actually an unmet need for us. Yeah, that the cannulas will shift and move.
So now I think it's difficult to move to us back to 20 gauge.
Yeah.
So we have to improvise with the newer technology only. So please,
Yeah,
Neha, you wanted, Dr. Neha wanted to ask.
Excellent presentation. I was just asking what Dr. Ajay has only asked, that the 6 mm infusion cannula, is it available for 23 or 25 gauge with Alcon or anybody else? Because if there is a case where I expect choroidal detachment, then I also go ahead and put, or in children quite often, put 6 mm 20 gauge sutured infusion cannula. So because I'm not aware if it's there in 25 gauge, the 6 mm infusion.
Yeah, I'm not sure. I think it's
So-
only 23.
There is a company in Jaipur which makes a 23. It's not available from the routine this thing, which make 23 gauge 6 millimeter cannula. I got it made specially from them, and it comes with the name of Ovation. I don't hear about him more, so I hope the company exists. But if it does, they have this cannula available.
Because it is an unmet need, and both the cannula, the trocar cannula part as well as the infusion cannula need to be 6 mm. Otherwise, either of them can slip out.
Yep, absolutely,
Thank you.
Manisha.